Good evening. I'm Mike Slowey from Coastal Fertility Specialists, and tonight is our second part of our five-part series on the basics of infertility. Last week, we all gave you an introduction to our practice, and tonight I'm going to go through the basic infertility evaluation and some of the basic treatments. And we'll follow that up with a discussion of in vitro fertilization, egg donation, egg freezing and sperm freezing, the use of donor sperm, and then we'll talk about financial things down the line. So let's get started. All right, so what we're going to do tonight, we're going to review the basic infertility evaluation and then again talk about our initial treatment options. So let's talk about infertility. Infertility is defined as the inability to conceive after a year of unprotected intercourse. Note the terms in red, unprotected intercourse. This does not mean we have to be using ovulation predictor kits. It does not mean we have to have the candles lit or the night's dinners, although those things are welcome. It just means, like our parents told us, if you're not using effective contraception, you're trying to be a parent. About 10 to 14% of our couples worldwide are infertile. So it's about 1 in 8 to 1 in 10. That's quite a few number of folks, and it can translate into 25 to 30 million people worldwide. Our evaluation is pretty straightforward. What is the cause of infertility? What is the prognosis for a live birth, given what we have to work with? Will direct further evaluation. So our initial evaluation says, what other steps do we need to take? And we want to decrease the health risks for the mom and the baby. So there's a variety of different causes. There can be problems with the ovaries, with ovulation. There can be problems in the abdomen with adhesions, endometriosis. Guys, we're either part of the problem or part of the solution. Male factor is quite a few of our problems, and then problems with the uterus. But notice there's a large amount of people that our basic evaluation doesn't yield what we call problem. That's what we call unexplained infertility. That means there are subtle problems there. Do the tubes pick up the eggs? Does the sperm survive the vagina and the cervix and the uterus? Does the tube transport the egg in one direction and the sperm in the other direction? Does the tube provide the proper environment for fertilization? Is the uterus receptive? Those are all subtle things that can nickel and dime a couple. All right, what do we look at? Well, it's pretty straightforward. We have the anatomy here. So we're going to look at the ovaries and how they're functioning. We're going to look at the uterus itself, the overall shape of it. Are there problems with the muscle? Are the fallopian tubes open? Is there scar tissue that's a potential problem? And of course, we got to look at the sperm. Hallmark of evaluation of the male is the semen analysis, and it's important because about 30 to 40% of our couples are going to have a problem with the sperm. Now, when I'm looking at a semen analysis, I'm actually asking a pretty simple question. How can I deliver the sperm to the egg? And I have three options: intercourse, artificial insemination, in vitro fertilization. Artificial insemination, which we'll talk about in a bit, is where we take the sperm, process it, put it directly into the uterus. So we bypass the major loss points, the vagina and the cervix, simply more sperm closer to where they're supposed to go. In vitro fertilization, that Dr. Schnorr will talk about next week, is where the sperm and the egg are put together in the laboratory. Embryos develop, and ultimately we're transferring an embryo. From a sperm standpoint, we have a neat technique called ICSI, Intracytoplasmic sperm injection, where we can inject the sperm into the egg. That's what we use when we have really significant sperm problems. So it starts with a semen analysis. Look at the concentration, the motility, the morphology. How do they look? And then if there's problems, there's a whole secondary evaluation to go through. Hormonal testing, sometimes genetic testing. Often we should get an evaluation with a urologist who specializes in infertility. And then they can be using imaging studies and on occasion advanced sperm studies. After we do that, we have to figure out what's going on with the ovaries. There's two aspects. Number one, is the woman ovulating? And number two, where is she in the aging process? This is a fun picture that I took probably 25 years ago. This is an ovary, this is a follicle, and right there is a little cumulus complex containing the egg oozing onto the surface of the ovary. Ovulation It's not like popping a balloon. It is a slow enzymatic process that takes 38 to 40 hours. And that's actually a very rare picture of that. So what do we look at? Well, the simplest thing to look at is the woman's menstrual history. Very simply, if you're having regular periods, you're ovulating, because you couldn't have a period month after month after month without doing that. There's other things to do, the old school temperature charts, the ovulation predictor kits, check progesterone levels. If you don't like somebody, you can do an endometrial biopsy. I promise those hurt, so we don't do those very often. And then we can have a good idea what's going on with the ultrasound at a given time. But at the first visit, that's probably telling me the most. Then, where are the ovaries in the aging process? This is very important because the way women age from a reproductive standpoint is very different than men. With guys, we don't make any sperm till puberty, but then we should be making sperm the rest of our lives. Women, on the other hand, are born with a finite number of eggs, typically around 1 million. By the time you hit puberty, you're down to 500,000. And then from puberty on, we're using them up at a rate of about 600 to 800 a month as they go through a 3-month developmental process. What you're seeing in your regular menstrual cycle is, in fact, the last month of a 3-month process. But over time, we're using them up and using them up, using them up, and eventually hit such a low number the ovaries quit working, menopause, and the average age is 51. But we lose the ability to get pregnant 7 to 12 years before that, late 30s, early 40s, because of the damage the eggs accumulate. Now, that's just going through life. Everything we eat and drink, inhale, whatever we do, we damage ourselves. And the eggs don't have a sense of humor about it. They're very easy to damage, and they're very bad at fixing themselves. So a given egg will accumulate damage over time, and reach a point where they're not going to work. Fewer normal eggs. And it's the same for everybody. I don't care if you're 20 or 30 or 40, it's the same process. Where are you in that process? So these are the tests that we look at. We have our day 3 FSH level is what we're focusing on. At the initial visit, we're doing our basal follicle count. And then a good test that we also get now is the anti-Müllerian hormone. These are other tests that you can use at times, but we just don't seem to use much anymore. All right, evaluation of the uterus and the fallopian tubes. Well, what are the problems that we're looking for? Of the fallopian tubes, we're looking for pelvic adhesions, scar tissue, which alter the ability of the tube to get to the ovary to pick up the egg. Endometriosis, a condition where there is inflammation that can cause scarring and pain and maybe creates a hostile chemical environment for the whole process to work. In terms of the uterus, we have polyps that we're looking for, outgrowths of the lining of the uterus, fibroids, which are common benign tumors of the uterus, Müllerian anomalies, birth defects of the uterus. They're fairly common. Asherman syndrome is scar tissue in the uterus. Endometritis is an inflammatory process in the lining of the uterus. And then, is the lining developing appropriately? So those are the things that we're looking for. My tools, well, of course, I have my initial ultrasound to start to look for things. And then a major test that we do early on is the hysterosalpingogram. We're going to look at some images in just a moment. Sometimes a test that might be a little more accurate at looking at the uterus is the saline sonography, but it doesn't do a very good job of telling me about the tubes. This tells me about both uterus and tubes, which of course are very important. Certain uterine problems can be best looked at with magnetic resonance imaging. And then of course we have surgical evaluation depending on what we're looking at. And of course at the surgery, you're also trying to solve the problem while you're there. So this is an HSG, hysterosalpingogram. What we do is we have a little catheter that we put in the uterus and we inject the X-ray dye. Shows us, in this case, a nice, beautiful uterine cavity. And then we see the fallopian tubes come out. The thin part of the fallopian tubes is called the isthmus. And the thicker part right here is the ampulla, which is where fertilization occurs. And this stuff out here and here is the dye coming out of the tube. So this is a real pretty normal HSG. Now, this one looks quite a bit different. This tube is very abnormal. It's blocked at the end, and so it swells up with the fluid that's in it and with the X-ray fluid. This is called a hydrosalpinx. In a day gone by when I was young, we try to fix it. That's why we know now not to do it, because these are tubes that are very, very damaged, and you can fix them, but as the old saying goes, you can't make silk out of a sow's ear, okay? So now what we do is we remove them, because number one, they can get bigger, they can twist and cause pain. They can cause pain just from dilating, and the fluid can leak back into the uterus and prevent an embryo from implanting. So we like to get those out of there. Now, what's not coming across real well on the computer is there are some subtle hints in here of something in there. This nice looking shaped uterus had a whole forest of polyps, which is actually easier to see on the original x-ray. Then here's another thing that we can see. This uterine cavity doesn't look like the other ones you've seen, have you? This is what's called a bicornuate uterus. This is a uterine anomaly. The actual outside of the uterus looks just like that, and so it looks like a pair of rabbit ears. Generally, we don't fix those unless there's multiple miscarriages. And here's a nice, beautiful fallopian tube that happens to go with that one. And then on this side is a very abnormal fallopian tube because it's been very damaged by infection. And these are little diverticuli actually off the tube. All right, this is what we see at laparoscopy. This is a very normal fallopian tube. Now, I want you to pay attention to this because we're going to look at an abnormal tube in the next slide. Nice, thin, very nice, fluffy, what we call fimbria, fingers that will take and pick up the egg off the ovary. And this is a very nice, normal reproductive age woman's ovary. So that's what normal anatomy look like there. This is what a hydrosalpinx actually looks like in real life. Notice how much bigger it is, and so you can tell how damaged it is. And so that's something we remove. You can see a little bit of the uterus right there. Right here, this is scar tissue, adhesions. Looks like the cobwebs in a Raiders of the Lost Ark, but it's often a lot thicker than that. And you can see it sometimes will have blood vessels, but what it does is distorts the anatomy and can make it hard to get pregnant because of that. Then we have endometriosis, which is tissue like the lining of your uterus that's growing out in your pelvis. And so it is able to respond hormonally, and it grows, and it stabilizes, and then it sheds. And that bleeding inside causes pain, it causes inflammation, which in turn causes scarring. It has many different appearances. This is brown endometriosis, there's blue endometriosis, there's the classic red endometriosis, and this is an endometriosis cyst of the ovary. Endometriosis is very happy when it finds the ovary because it just found hormone central. And you can get these big cysts, and then there's bleeding inside the ovary, and it collects inside the ovary. Well, when blood oxidizes, it goes from red to brown to black, and so inside this, you open it up, it looks like Hershey's syrup. It's about the same consistency too. I wouldn't advise tasting it. All right, when we're looking at the uterus, we have our just basic ultrasound. You can see the outline of the uterus here, and this is a beautiful lining in the follicular phase. So that's what we see like on a regular ultrasound. We have our HSG, that picture should look familiar to you. And this is what the saline sonography looks like. Here we've got a uterus, we're looking with ultrasound, and right here we can see a fibroid, and both of these are altering the uterine cavity. This should be a nice black oval right there. And so we had to do what's called hysteroscopy, which is looking in the uterus, which is what we're doing here to get those out. And these are what polyps look like soft little stalactites and stalagmites. All right, about a quarter of our patients will have no explanation at all for that, but yet nearly half of our patients will actually have multiple problems. That's why at the first visit, we're talking about looking at the sperm, looking at the eggs, looking at the pathway, because we don't want to miss something and waste your time, money, and more importantly, your emotional currency because we missed something, all right? Now, so that's the basic infertility evaluation, sperm, eggs, pathway. And needless to say, that can lead us to further evaluation in a variety of different ways. Now, when we're getting ready to start our therapy, there are basic goals of that therapy. Number one, we want to have a healthy child, right? That's what everybody's goal is, walking in the door, and that's what we want you to walk out with. Number two, we don't want to compromise the health of your mother. Now, most of these therapies are really, really quite safe, but the moms often bring to us health risks, and we have to balance those health risks for the mom in attempts to getting pregnant. And of course, we want to minimize as much as possible the financial risks, the emotional risks, and the turmoil that goes with doing all this. All right. So one of the basic treatments that we have is ovulation induction. That means we're either causing somebody to ovulate or we're trying to get multiple eggs to work with. So for women who don't ovulate, our goal is to simply get one follicle at a time, which is what you're supposed to get every month. If we do that for them, the pregnancy rates are actually very good for them. Now, For women who are ovulating, so for example, our endometriosis patients or our unexplained infertility patients, we want to try to get a number of follicles, but not too many, because we don't want you to have your own reality TV show, at least not kind of us, right? Our goal is 2 or 3 or 4. Now, 2 different classes of medicines, oral medicines and injectable medicines. There are 3 oral medicines: Clomid, letrozole, tamoxifen. Interestingly, all 3 were developed as breast cancer treatment. Clomid in the 50s, tamoxifen in the 60s, and letrozole in the 80s. From a practical standpoint, they work in a similar manner by increasing FSH. They make your brain think there's low estrogen, and in response, your pituitary releases the FSH, which goes to the ovaries to cause the follicles to grow. Then we have injectable medicines, which is a group we call gonadotropins. That is tropic, meaning stimulate, so drugs that stimulate the gonads. These actually contain FSH. Now, it's really important because here, with the oral medicines, your feedback system's protecting you. Here, we're blowing right by the feedback system, so we have to protect you. That's why these have to be monitored closely with the ultrasound and blood work to make sure we're not getting excessive development. So, how do we do that? Ultrasound transvaginally, and so you can see the follicles, the number of them that are developing, and the size of them tells us about how mature they are. And the estrogen levels are very helpful in telling us how active those follicles are. In a typical cycle, and again, this is primarily with gonadotropins, because the oral medicines don't have to be monitored that closely, the follicles are developed over 7 to 10 days, and then we give the hormone HCG, the pregnancy hormone, to cause ovulation to occur, which occurs 38 to 40 hours after the injection. And then we time the sperm delivery, either the intercourse or artificial insemination, for some time before the egg is released, okay? All right, artificial insemination is where we take the sperm, process it, and then ultimately put it up inside the uterus. Now we have to process the sperm because the sperm comes in a vehicle, the semen. The semen is meant for the vagina, not the inside of the uterus. So in processing the sperm, we're going to lose some of the sperm. But guys with a good sperm count do well, but there are a lot of guys with not so good sperm counts that don't do very well with this because we get below a threshold where this process works. So basically what we do is we put a speculum in the vagina. We have this little tiny catheter right here. It's soft and flexible. We place it up in the uterus and we inject the processed sperm, and it's usually in about a 0.5 milliliter solution. For patients with unexplained infertility and our endometriosis patient, it actually doubles the pregnancy rates when used with the medicines. Now, how well does this work? This is a paper that my partner, Dr. Schnorr, published several years ago with our protocol that we use. And basically what you see is pregnancy rates of about 25% per cycle. Now, that may not sound like very much, but remember, normal fertility is only 20% per month in women under 40. So and the unexplained infertility group without treatment is only 3 to 4% per month. So you're talking about 8 times the baseline pregnancy rate with this. And what happens here, then it adds up, is over 3 months, you get about 40 to 45% of the women pregnant with a relatively simple treatment. But notice how much it drops off over 40. That's because we're dealing with a limited number of normal eggs. What if only 10% of the eggs are normal? Well, that means I've got to go through 3 cycles to maybe have 1 or 2 that are actually good and have a chance to make a baby. And we don't know if the tube picked those up, if the sperm found them, or things like that. So in this younger group, there's enough normal eggs that the pregnancy rates stay pretty good. But as we get over 40, this isn't going to work as well. All right. So what about the risks of this? Because everything's got risks associated with it. Well, pretty much the biggest risk walking in the door of our office or any fertility center is multiple pregnancy. And it's a risk because you're designed to carry 1 baby at a time. The more that we have in there, all the risks of pregnancy increase: gestational diabetes, preeclampsia, fetal growth issues, preterm labor, preterm delivery, and all the bad things that can happen to the babies from delivering too soon. In just twins, those risks are increased by 2 to 5 times. You don't want to hear the number for more than twins, okay? So our goal is always 1 baby at a time. Now, the oral medicines with the older 2, tamoxifen, and Clomid, the risk of twins is about 8 to 10%. The newer medicine, letrozole, has about a 4 to 5% risk of twins. More than twins is really unusual with an oral medicine. With the injectable medicine, it really depends on how well you manage the cycle more than anything else. If you look in the literature, you'll see a risk of multiple pregnancy of 15 to 20%, with 1 to 5% being triplets or more. In our practice, we have about a 10% risk of twins because we're very judicious in the management of this. And it's very, very, very rare for us to have more than twins. And then there's a condition called hyperstimulation syndrome, where there are growth factors and hormones made by the ovaries that cause fluid shifts. Your tummy fills up with fluid. Not only do you feel miserable, but there's a risk of clotting problems, electrolyte problems. Functionally, in these types of treatments, it does not occur, period. I have not seen a case of hyperstimulation in a ovulation induction cycle in over 25 years. And that just means you're managing the cycles properly. In vitro fertilization, it can come into play, but as John will go into next week, there are some different medicines that we use that can almost eliminate that risk there as well. All right. And finally, what if my partner doesn't have any sperm? This is a common thing that we have to deal with because the male partner has a problem and he's what we call azospermic. He's not even making sperm in his testes. We have plenty of single women that come in to start their families. And of course, we have plenty of couples that are lesbian couples. And so we need to get sperm there. We can get this sperm from sperm banks. Of course, adoption, child-free living are options. But there's a number of high-quality sperm banks out there. We don't actually care which one you work with. We want to be a little bit careful. We don't want to use Bob's Internet Sperm Bank. We want to use one of the places that the government pays attention to. And we go through the same basic infertility evaluation. Obviously, we are not doing the male evaluation for the women with no partner and our lesbian couples. But for the guys, if they haven't had an evaluation, it's really important if they're azospermic because there are some very significant medical problems that could be there. So you got to make sure you go through there. And then we can use artificial insemination. Whole playbook's open. Natural cycles, stimulated cycles like we just talked about, IVF. So the sperm travels very well. All right, this is what I've got. So infertility is a common treatment, 10 to 15% of reproductive age women. Our evaluation is actually much simpler than what it was when I started out almost 30 years ago. Sperm, eggs, pathway. The focus of the testing is directed at establishing the chances of attaining a healthy pregnancy and keeping the mom in one piece. Many couples can be treated with low-tech treatments. For example, our women who don't ovulate, we're almost always starting out with the oral medicines, and they can work pretty well. So we're just not a center that does IVF. We are a center that provides full service based on what the evaluation tells us. And it's really important to understand, and I think all of us are going to emphasize this, persistence is important. Normal human reproduction is not a particularly efficient process. And oftentimes we're just trying to tweak the process to get us in there. But that's why persistent. Look at what's normal. 20% per month, but 2/3 are pregnant in 6 months, 85% are pregnant in a year. And with us, we just got to keep coming up to the plate, take our swings, we'll hit the home run eventually if you just keep with it. That's all I've got today. Now, let's see if we have any questions.
Yes, we have one from, well, first of all, Ashley Patton wanted to say hi.
Oh, Ashley.
We love Dr. Slowey and everyone at Coastal. He helped us make our miracle baby who turned 2 a week ago.
We got your hands full there.
And then I've got Kiosha Dickey is a new patient of yours. So she found out about us from Instagram. Okay, first question is from Kiosha. She wanted to know if the HSG is a painful process.
I'll be brief, yes. But we're all different, okay? Needless to say, I've never had one. But I've done several thousand of them, probably over 10,000. It varies from person to person. The real trick with the HSG is, number one, getting the catheter in the right place, inflating the balloon on the catheter just the right amount, and then very slowly pushing the contrast. you really see a full range of responses from people who really don't feel very much at all. And there are occasional people, unfortunately not very often, where it is exceedingly painful. So I'd be lying if I said it wasn't bad. For most women, it's like menstrual cramping. We like you to load up with some Motrin or Aleve beforehand, and you tend to do really, really well. When we've got blocked fallopian tubes, particularly like the hydros that I showed you, sometimes that can be uncomfortable. But in general, I think everyone does really well. We all take our time, but it actually goes pretty quick, and we use techniques to try to minimize the discomfort for you. For example, we keep the contrast in a warmer. Studies have shown that the warm contrast creates less pain than cold contrast. So we try to do all the things that we can to minimize it. But yeah, I think some menstrual cramping would be the best description, and we'll do a good job for you. All right, what else do we have?
Okay, so Delicia says, is there a good time during the menstruation cycle to come in for evaluation? For example, right after the cycle ends or right before anticipating ovulation?
Well, we are happy to see you anytime during the cycle, because things like basal follicle counts and what the uterus looks like are, we know where you are and it's easy to work with. Early in the cycle is nice because we're at baseline, so we can get those ovarian reserve testing labs right away. We can get the HSG done probably within a week. But it really should fit your schedule more than anything else. We're happy to see you at any time during the cycle. Doesn't matter to us if somebody's bleeding. Everyone worries about that. But with all these cycle starts for all the treatments, women are bleeding all over the place here. So we are not worried about that one bit. I know it might be yucky for you, and that's understandable. So come in at a time when it's convenient for you. We'll make it work. Okay?
Okay, one more.
Yes, ma'am.
This is from Janae, and she wanted to know, are there any sperm banks in Charleston? If so, is there one that you would recommend?
We do not have any sperm banks in Charleston. Fortunately, sperm is very portable, and there are a number of high-quality sperm banks throughout the United States. And we would want you to look at them individually, and we'll give you a list of them. We don't prefer one or the other because we're not the ones trying to match the different things that you're looking for. So we're happy to work with whoever, and we can give you a list of reputable sperm banks to work with.
Okay.
All right.
I think that's all for now.
Okay.
Yeah.
Well, those are all the questions that we have. Thank you so much for taking your time away from watching the election results, and hopefully we'll be done with that at some point. Anyways, thank you very much for your time, and I hope if I don't get to see everyone again, I hope you have a wonderful Thanksgiving. Have a good night.